Let's talk about the joints, and we're going to start with the definition of a joint. Joint is a place where two bones meet. That's it. So joints can be classified functionally, the degree of motion, and structurally, what connects the bones. So functionally, bones can be classified into non-movable, called synarthrosis, slightly movable, amphiarthrosis, and freely movable, diarthrosis. Structurally, joints can be fibrous when ends of the bones are connected by the collagen fibers. Three types listed here. We're going to talk about them: sutures, syndesmosis, gymphosis. All of them are immobile or slightly mobile. Cartilaginous joints, where bone ends are connected by hyaline cartilage or fibrous cartilage. Synchondrosis and symphysis usually are immobile or slightly movable. And the only freely movable joints in the human body are synovial joints. End of the bones are enclosed in articular capsule, and the ends are covered with the hyaline cartilage. So fibrous joints are characterized by the bone ends connected by the connective tissue. So no joint cavity, most of them are immovable. Sutures that can be found exclusively in the cranium. Here you can see two bones are connected by the very, very, very short connective tissue fibers. Not movable when we reach middle age. The connective tissue in the sutures ossify and essentially fuse, and they become synostotic joints. So that part becomes a bone. Syndesmotic joints. Usually no movement or very little movement. Two bones are connected by the ligaments, bands basically, of the connective tissue. So for instance, tibiofibular joint here, immovable. There's a joint that is formed by the radius and ulnar, the bones of the forearm. So radio-ulnar joint is movable. You can see it if you will try to pronate and then supinate your arm. Gymphosis are very interesting joints. That's a joint between the teeth. Here you see the tooth and the alveolar processes of the upper or lower jaw. So tooth sits in the socket, and periodontal ligament here connects the tooth to the bone. So that's basically, you have 32 joints in your mouth. Obviously, gymphosis are immovable joints. Cartilaginous joints. Synchondrosis. Practically all synchondrotic joints are immovable, meaning they are synarthrotic. So for instance, here you can see a plate of the hyaline cartilage that connects ribs to the sternum. Okay. The epiphyseal plate that we discussed in a different lecture, it's a temporary joint because it connects two parts of the bone. Okay. No cavity, obviously. Symphysis. In symphysis, bones are connected not by hyaline, but fibrocartilage. All the joints between the adjacent vertebrae are symphysis. Pubic symphysis, the joint between two hip bones, is another example. They are usually amphiarthrotic, so you think about your spine, you can flex it, and the pubic symphysis allows for some mobility, especially during the delivery of a baby. Synovial joints. In this case, bones are separated by the fluid-filled joint cavity. all synovial joints are diarthrotic, meaning that they freely move. All limb joints, well, almost all, radioulnar is not, but practically all limb joints are synovial joints. That's the vast majority of the joints in the body. So let's talk about parts of the synovial joint. Articular surface, covered with a hyaline cartilage. Joint cavity or synovial cavity. So that beige is the synovial fluid that fills the synovial cavity. Articular capsule can be seen here. It's the fibrous layer that encloses the joint. Deep to the articular capsule, you can see the synovial membrane. So that membrane right here, the beige one, the darker beige, is a connective tissue that produces synovial fluid. That same fluid that fills up the cavity. Synovial joints usually have reinforcing ligaments. They are not shown on the picture, but ligaments, bands of dense connective tissue holding together bones, can be extracapsular, outside of the articular capsule. Capsular, essentially capsular ligament is the one that basically forms the articular capsule. And they can be intracapsular. If we have a ligament somewhere here, that would be intracapsular ligament. It's inside the capsule. There are nerves in each joint, obviously, to detect pain and monitor the joint position and the joint stretch. And there are blood vessels that supply synovial membrane to produce, filtrate, and form synovial fluid. Some joints, not all of them, but some synovial joints have other elements. For instance, they have fatty pads. So this fatty pad in the knee joint provides the cushioning between the synovial membrane and the outside fibrous layer. Articular discs made of fibrocartilage, menisci, here you can see meniscus and meniscus here. They usually improve feet between the articulating bones, and it reduces wear and tear damage to the joint. Bursae. Bursae is a really interesting structure. Here's the bursa. So bursae are like rolling bearings. They're sacs. Outside of the sacs is synovial membrane, and inside is synovial fluid. So they're like soft bearings that separate, in this case, the connective tissue on the outside from the patella. That's prepatellar bursa. Prepatellar bursa rolls like a bearing, reducing the friction between the bones and the ligaments or tendons of the muscles. Extension, sort of a next level of bursa, is tendon sheath. That's the elongated bursa that completely wraps around the tendon and prevents the friction of a tendon against the bone. So we all tend to think about joints sometimes being unstable. So what actually stabilizes the joint? The main stabilizing factors for the joint are the shapes of articular surface. So that's going to be shape of articular surface. Number of ligaments. You see that in the knee joint there are plenty of ligaments. For instance, anterior crucial. And muscle tendons that cross the joint. So basically, which muscles move the joint. So the least important is shapes of articular surfaces. More important is number of ligaments and their position, but the most important are the muscle tendons that cross the joint. So for instance, hip joint or knee joint are relatively stable joints because muscles that cross knee or hip are quite massive. Those are muscles in a leg. You know, they big muscles, they strong muscles usually. Elbow is not as strong because muscles that move the elbow joint are weaker, like rotator cuff muscles. So essentially, in order to provide a joint with higher stability, if you train your muscles, if you make them stronger, that's good. That will stabilize the joint. Now, movements, another type of functional classification of the joints based on the movements. So joints, synovial joints, of course, can produce 6 types of movements. They can be pivot joints. So that will be the joint between the first and second vertebrae, atlantoaxial joint. And the movement here you can see is going to be uniaxial, one axis. They can be hinge joint, like an elbow, again, uniaxial joint. It can be saddle joint. Saddle joints are between the metacarpals and carpal bones. Plane joints. Plane joints are between carpals or between tarsals. Condyloid joints is a biaxial. This is non-axial. Saddle is biaxial. Condyloid is biaxial. Condyloid joint is a joint between the thumb and the carpals. And finally, ball and socket joint. That's 6th type. That's multi-axial. It has multiple planes. It can move in multiple axes. So now we're going to chat about some movements of the joint. The first types of movements that we're going to be talking about are flexion and extension. Flexion and extension occur in the either mid-sagittal or transverse plane. So and the difference is when you're flexing, the angle between the axis and the limb or whatever body part you're flexing decreases. So if this is an axis and you're flexing, the angle becomes smaller. When you extend, the angle becomes higher. So when you flex your elbow, you decrease the angle. When you extend your elbow, you increase your angle. So those are some examples. Flexing knee, extending knee. Flexing a head, extending the head. Flexing the trunk, extending the trunk. Abduction and adduction, as well, movements that occur in the coronal plane. When you take the limb away from the central line, that's abduction. You abduct your limb. When you bring it back to the central line, it's adduction. Circumduction is when the end of the limb is not moving, but the proximal end of the limb is not moving, but the distal end of the limb makes a circle. So essentially, you're kind of making a cone with your limb. Rotation. You rotate your head, or you can rotate your hip laterally or medially. Pronation and supination. When you hold your arm forward and your palm is facing up, that's that's supinated position. You carry a bowl of soup. When your palm is facing the floor and you stick your arms forward, that's pronated position. The feet. Standing on your toes, plantar flexion. Standing on your heels, your foot in a dorsiflexion. When you walk on the outer side of your foot, that's inversion. When you walk on the medial side of your foot, that's eversion. There's some special movements also in the head. So protraction and retraction of mandible, moving mandible forward and backwards. Elevation and depression of the mandible. That's what you do when you chew. Opposition, for instance, when you make a ring from your index finger and a thumb. Now let's talk about the general anatomy of certain joints, synovial joints in the body. First one will be the knee joint. It's the largest and the most complex joint in the human body. Essentially, it's a 3 joints. The joint between the femur and the patellar, femoropatellar joint, and 2 tibiofemoral joints, lateral and medial. So, for example, here you can see, I don't know, medial femoropatellar joint. So this part will be the lateral femoropatellar joint. This part will be the medial. Not femoral, sorry. Lateral tibiofemoral and medial tibiofemoral. Only one femoropatellar. It can flex, it can extend, some very minimal rotation. So multiple muscles that cross the joint, such as quadriceps muscles and hamstrings, they reinforce the capsule by their tendons. So capsule itself is almost non-existent. Tendons of the muscles serve as the capsular walls. So you can see here you have patellar retinacula, patellar ligament, patellar tendon. They all form anterior wall of the capsule. Now, 2 collateral ligaments that prevent the hyperextension of the knee, tibial collateral and fibular collateral ligaments. In the back, they're not in the picture, there are oblique popliteal and arcuate popliteal ligament posteriorly. And of course, everybody knows about the anterior and posterior cruciate ligaments. So here is the anterior cruciate ligament, and this is the posterior cruciate ligament. They're called cruciate because they cross from one side to another. This end of the ligament here and this end of the ligament here, these ends are attached to the femur, which is not shown on the picture. These ligaments prevent the anterior and posterior displacement of the knee. So they prevent your lower leg, your tibia, from moving freely forward and backwards. So what happens if somebody experiences the lateral blow into the knee? First, tibial collateral ligament is being torn. Then anterior cruciate ligament is torn, and then the meniscus is going to be torn. So these 3 things, tibial collateral, anterior cruciate and medial meniscus, are elements of the knee that can be damaged as the result of the lateral blow to the knee. Shoulder joint. The type is ball and socket. Most freely moving joint in the human body, but the stability is sacrificed. There are some reinforcing ligaments, some of them are absent sometimes. So coracohumeral ligament, the one, it's not shown on the picture, but it's basically a ligament that connects coracoid process of the scapula to the humerus. Glenohumeral ligaments form a joint cavity, but they are often absent. The main reinforcing structure that stabilizes the shoulder joint are the tendons of the muscles that cross this joint. So tendons of biceps brachii, tendons of rotator cuff muscles, but you can imagine that rotator cuff muscles are relatively small. They aren't very strong, and since they aren't very strong, they cannot provide sufficient stability to that joint. Elbow joint is the hinge joint, and it is formed by two articulations, articulation of the ulna with the humerus, and articulation of the radius with the humerus. So in this image, actually, there are some mistakes. We'll get there. We'll get there. So there are three main ligaments that stabilize this joint. Annular ligament that goes around radius, radial collateral ligament shown here, and ulnar collateral ligament shown here. So these ligaments restrict the movement of the side to side, but the main stabilizing factor for the elbow joint would be the tendons of the muscles that cross it, basically tendons of biceps brachii and triceps brachii. Hip joint looks very similar to the shoulder joint. It's also ball and socket, but it's more stable than the shoulder joint, which means its mobility is sacrificed. Not completely, you have to understand that. It's still pretty mobile, but you see the socket, so head of the femur sits in the acetabulum of the hip bone. So that deep socket somewhat limits the mobility of the joint, but provides extra stability. Also, you can kind of see this green band of cartilage. It's so-called acetabular labrum. Labrum means a lip. So it's a lip that surrounds the head of the femur and provides extra stability. Ligaments that reinforce this joint is the ligamentum teres, or the ligament of the femoral head, right here. So this ligamentum teres. Iliofemoral ligament that connects ilium to the femur. Ischiofemoral ligament that connects femur to the ischium, the posterior part of the hip joint, and pubofemoral ligament that connects femur to the pubis. Temporomandibular joint. So in this case, you see the condyle of the mandible articulating with the mandibular fossa in the temporal bone. You see that there are two joint cavities and several articular discs. This is the most easily dislocated joint in the body. Not a lot of strong muscles cross it, and not a lot of ligaments stabilize it. The movements that it can produce are gliding movements, side to side, when you grind with your teeth. That's lateral movements. And there are some hinge movements. The elevation and depression of the mandible is the result of the hinge motion at the TMJ. So there are some common joint injuries. First one will be the cartilage tear. Here you can see torn meniscus. The fragments of the meniscus, for instance, can lock the joint, so it will reduce the mobility. The problem is that cartilage is poorly vascularized, so it doesn't really well repair itself. So it's usually the cartilage tear is repaired by so-called arthroscopic surgery, when surgeon inserts the instruments into the joint and removes the fragments and repairs the ligaments. But the problem is that when meniscus is removed even partially, the joint becomes less stable. Eventually it will lead to more injury, and more meniscus is going to be removed. So eventually complete removal of meniscus will lead to inflammation of the joint and osteoarthritis. Sprains, stretching or tearing the ligaments that reinforce the joint. Again, ligaments are not vascularized, so poor oxygen and nutrient delivery slows down the repair. If the ligament is completely torn, like in this image, you can sew the ends. You can replace the ligament with a graft. Poor vascularization in this case, is kind of beneficial. No rejection. Or just give it time and immobilize it and hope that it'll grow back. Dislocations or luxations. You can see a complete luxation. Here, it may lead to sprains to the ligaments surrounding the joint, inflammation, put the bones back in place, let it sit for a while, don't immobilize it, give it time. Subluxation, partial dislocation of a joint. Bursitis, inflammation of a bursa. When you stand on your knees for a long time, may lead to the inflammation of bursa known as bursitis. Anti-inflammatory drugs is the answer. Tendonitis, inflammation of a tendon sheath. Usually overused. Tennis elbow, golf elbow. So you can see tendonitis here. Symptoms, pain, treatment, anti-inflammatory drugs. In some cases with tendonitis, surgery may help to remove the inflamed, damaged tissue. Arthritis, degenerative disease that damages the joint. So there are four types that we're going to talk about. Arthritis can be chronic and acute. Acute arthritis is usually of infectious etiology. The first type that we're going to talk about is osteoarthritis. Reversible, degenerative wear and tear arthritis. Excessive use of a joint. 85% of Americans develop osteoarthritis. Half of Americans by age 85 develop osteoarthritis. Women are more susceptible to it, probably because of the decreasing levels of estrogen after the menopause. It's kind of normal. You can see arthritic hip here. So what happens? Cartilage is destroyed. Articular cartilage is destroyed. It's not properly replaced. Bone ends rub against each other, thicken, become bigger, form spurs, restrict movement. May actually grow together, fuse. Treatment, paradoxically, is the physical activity to move the joint. Pain relievers, capsaicin creams that contain chemical known as capsaicin. It's basically pepper, which takes away the painful sensation. It doesn't really cure anything, it just takes away the painful sensation. Nutritional supplements like chondroitin sulfate and glucosamine are not effective in the treatment of arthritis. There were multiple studies showing that they are not. Rheumatoid arthritis, chronic autoimmune disease. Nobody knows what causes it. Your immune system attacks synovial membrane. Middle-aged, mostly in women than in men. Swelling, joint pain, anemia, osteoporosis. You see the list of the symptoms, but joint pain. You can see osteoarthritic hands here. So first, there's an inflammation of the synovial membrane known as synoviitis. Synovial fluid accumulates as the result of synoviitis, which leads to the joint swelling. Synovial membrane thickens, leading to the formation of pannus, which starts to erode articular cartilage. Eroded cartilage exposes the ends of the bones, which start to rub against each other, forming connective scar tissue between the bones, and that results in the fibrous ankylosis. Eventually, connective tissue ossifies, forming bony ankylosis. You can imagine at this point, a joint is not movable. Treatment: various drugs, anti-inflammatories, immunosuppressors. We have a drug called rituximab now, which inhibits the function of tumor necrosis factor, which is pro-inflammatory molecule. But eventually the joint has to be replaced with a prosthetic joint. Gouty arthritis: accumulation of the crystals of uric acid in soft tissues and joints, and in joints it leads to inflammation. You can see the crystals of uric acid here. More common in men, usually older. Affects usually joints in a foot, base of the great toe. If it's untreated, ends of the bones fuse and joint becomes immobilized. Treatment: there are drugs against it. Avoidance of alcohol. Alcohol increases the deposition of uric acid in the joints, and drinking plenty of water to basically dissolve that uric acid and remove it by kidneys. And finally, Lyme disease. That's an infection, so caused by a bacteria called Borrelia burgdorferi. It's transmitted by ticks, and after the initial tick bite, the person usually experiences fever and that condition known as erythema migrans, so bullseye rash. This image, you can see the distribution of cases in the United States, mostly in New England and northern Midwest. If at this stage disease is left untreated, microorganism migrates into the joints, causes inflammation of the joints and acute arthritis. Can be treated with antibiotics. However, at the arthritis stage, it is really hard to cure it, because it basically it can easily become chronic, and it's really hard for for drugs to reach into the joint and to kill the microorganism. So that concludes our conversation about the joints.